Welcome, Dr. Wright. We're really, really grateful to you for doing this video this evening. As you know, we're very fascinated by your work and particularly your research. So we've got a lot to learn from the work you're doing and how much you're helping patients with your techniques and the way you look at patients' requirements. And I do think one of the basic issues is when people are going to see a surgeon, are they properly diagnosed before they get to that surgeon? Is the surgeon the right person to diagnose them? And that's why I think your look-alike talk tonight is really, really essential for people to understand that basic process. Get the diagnosis, make sure the diagnosis is correct. Are there other conditions that need to be treated? And at what point is surgical intervention the most appropriate stage for somebody?
Thank you, Sherry, for that. And I think it's very important, properly diagnose lipedema and know the other things that can cause the presentation that looks like lipedema look-alike. So not every lady with large legs has lipedema. There are other conditions, and it's important to distinguish them because having the proper diagnosis is going to lead to the proper treatment. So only disclosure is Tactile Medical supported my research 4 years ago. So the first is is this lipedema? I mean, she's got large legs, and the answer is no. And so this is actually Madelung's disease. It's the mirror opposite of lipedema. So it accumulates on the upper body and can do the thighs, but characteristically it involves the arms and the trunk, and she has quite a bit of nodularity and her trunk, and she does have some in her thighs as well, but it's more focused on her upper body. So the type 1 is just around the neck, and type 2 is upper arms, and type 3 is the pelvic area, and also with type 3 it affects the thighs. So it is different. Metabolically, it's more associated with insulin resistance and more abnormalities in fat metabolism. It also occurs in men as well as women. In men, this is generally is associated with alcohol use. We don't see we don't see the pattern in women we don't see associated with alcohol use. Next, is this lipedema? And you can see she's got large arms and legs, but no, this is Dercum's disease. She's really not as disproportionate as someone with lipedema. It's a related lipomatosis, so it tends to be more fibrotic and caused by painful lipoma. So basically, a lipedema nodule both start with adipocytes or adipose cells that then become encased with fibrotic tissue. Now, if they're partially encased, that's a lipedema nodule, and then completely encased, that's a lipoma. Edema tends to be a less prominent feature. So it's also associated with more insulin resistance, infects men and women. In women, it commonly develops around menopause, and the surgery treatments are less effective for Dercum's than lipedema. It's this lipedema. Disproportionate, legs are bigger, but no. This is May-Thurner syndrome, also called iliac vein compression, sometimes one leg is more affected than the others, but can be symmetrical. It's pretty symmetrical in this lady. There's a higher risk of DVTs. And while we're there, there was just a recent paper that came out sponsored by the Lipedema Foundation that showed higher incidence of DVTs in lipedema and lymphedema. So iliac vein compression again, the pain is not necessarily relieved by if you do liposuction, you're not going to relieve the pain. The relief for if the vein compression is causing the pain, it really the treatment would be to stent and open that iliac vein. But the criteria for doing the stent should be strictly followed because some people have a mild amount of vein compression and it may not, and that just a mild amount may not cause symptoms. So surely this is lipedema. I mean, very, very disproportionate. I mean, her legs are large, no fat on her upper body. In fact, she's kind of ripped on her upper body. That's kind of a hint. No, it's not lipedema. It's actually acquired partial lipodystrophy, and this is a fat disorder, a fibrotic fat disorder, a lipomatosis, but it's also but it's caused by a febrile illness, and the fat loss occurs in the upper body, and of course surgery is not effective for this, and we diagnose this with low complement and biopsies. Is this lipedema? No, you guys may be detecting a pattern here. But this is actually lymphedema and obesity. So I'm going to go through this and kind of show the tip-offs why you might think. One, she is a larger lady. And then these hanging lobules, when they're like that, they're also sometimes called pseudosarcoma. These lobules, each of these are actually caused by lymphedema. So they occur in lipedema as well, but only when there's some significant lymphatic impairment. And basically these are areas where the lymphatic circulation is just severely compromised, so they swell and they get very hard. Now, classic lipedema is not hard tissue, but these get hard and they get the skin changes of lymphedema. And so that is different than, lipedema. And then, and you can see here, she's got very large cuffs, and you can see here it's also has extended onto her feet and hands, and so it is so the most common cause of lymphedema is actually obesity now in the developed world. Now in of course in the undeveloped world, filariasis is the most common cause. Now venous disease and trauma, the most common trauma associated with is that surgical trauma for cancer. So, and lipedema can also cause secondary lymphedema. Tip-off is that they on the feet and hands are swollen, and now that's most oftenly seen with primary lymphedema, but it's also in acquired lymphedema. It can also spare them, and that's also more commonly seen in secondary lymphedema caused by lipedema or venous disease. This is lipedema and lymphedema again. So this is lipedema, but she has these hardened. You can see from there that there's skin color changes, and you have to these are going to be hard, and the skin is not only tough but sort of pebbled texture to it. And these lobules are called pseudosarcoma, as I kind of said, and that can also be secondary to obesity. So is this lipedema? Yes and no. So yes, she has lipedema, but she also has obesity, and obesity is the most common disease in the United States, actually the developed world, and affects central. So there's central and visceral fat accumulation, more than the extremities. Now she is associated with metabolic diseases like diabetes and cardiovascular disease. Now she also has lipedema. So here is her before bariatric surgery and then after surgery. So you can see the waist is much, the abdominal visceral fat is gone, and now it's just really in her legs. And so she had both, and then but the lipedema persisted after the bariatric surgery. So in summary, there are a lot of diseases that look like lipedema. Misdiagnosis is common, and improper diagnosis leads to improper treatment and poor outcomes. Lipedema cannot be diagnosed by just looking at photos, and we do have some people that try and diagnose it without an exam and without the confirmatory tests, and I think that's unfortunate, and because it can lead to improper treatment. Lipedema is difficult to diagnose because we only have descriptive criteria, and this descriptive criteria can be caused by other diseases. Thank you very much for your attention. Ready to answer some questions.
Thank you very, very much. You've opened my eyes to lots of new definitions, and it worries me that a lot of people would have assumed these were lipedema and could have gone and signed up for surgery, because we know a lot of people are having online consultations and diagnosis. What skills do you need, or what training would either a surgeon or a medical expert or even a GP in the UK need to be able to make these distinctive distinctions between these different conditions and not assume they're lipedema, because as you say, there's no actual test for lipedema?
So I think that, these are physical exam skills that every physician should be able to master. But the issue is really what to pay attention to. And I've actually created a slide presentation about that, because it's very these visits to a GP or any doctor are focused on different things, and not the subcutaneous assessment of the subcutaneous tissue, assessment of lymphatics, assessment of these things that are required to diagnose lipedema. Not GPs can diagnose this vascular. There should be some confirmatory things. So the only way you're going to pick up the iliac vein would be a venous Doppler ultrasound. The only way, and the rare thing like acquired partial, but that would be. I mean, she was quite distinctive, but those are rare, and so not everybody would have a familiarity to think of it.
Sorry to interrupt you, but when we go to medical events and we talk to people we call in the UK GPs, general practitioners, who are the first port of call for a patient who's concerned about their symptoms and who they look to for a diagnosis. Once we've talked to a GP, for example, who's never heard of lipedema at that stage, and then they literally say to us, "Oh, I've got a patient like that.
Yeah.
Do I do next?" And that's where we find it really, really difficult, because the next stage is hard to find in the UK at the moment for various reasons, and shortage of expertise, I suppose you could say that. But I think from a patient's point of view, if you've asked your GP and the GP suspects you have something but doesn't have that second tier of expertise to make a referral to,
right,
the patient is more inclined to self-diagnose and look on the internet for information. And at the moment, it's almost inevitable they will see fabulous stories of people who've had liposuction somewhere in the world and wonderful results. And if you look like one of those people you put up there, you would compare yourself, I think, on social media with lipedema and look for a surgeon. And my big concern at the moment is this sort of self-diagnosis route and straight to surgery route, because there's a surgeon who also says it's lipedema and they can treat it, is both a waste of time for the patient and potentially you know, more dangerous. And,
Yeah.
and you know, what I would ask you, obviously with your expertise, is how do we develop a better system that prevents a patient going down the wrong route, if I put it like that?
Yeah. Well, I mean, so there's two parts to that question. One is we need to make sure we're properly diagnosing, and two, people need to understand that that lipedema is a systemic disease that needs to be treated comprehensively, and surgery is not a cure. And so the first part, though, would be to educate. Starts with awareness. Just any medical professional being aware that there is a thing, a lipedema. And then developing a competency and familiarity to diagnose it, and then um, recommending in conservative non-surgical treatments to manage it. And that and in the end of the day, even if you have surgery, no matter what, surgery is can be part of the equation, but it doesn't have to be. And managing it, no matter what, you will have to, even if you have surgery, you're going to have to manage the disease. You're going to have to be on a cleaner, more careful diet than people without this. Compression is almost certainly going to be part of your life, your whole life. That's really important. And then, I mean, surgery can be done, but you need to understand the limitations too of that. And I take your point very well. I mean, I think the person with a acquired partial dystrophy, the person with May-Thurner's, they're not going to get better by the surgery, and the people with Dercum's may get better, but they may not. And that's the thing. And so, it would be it's very frustrating for the patient who goes through this and goes through surgery and doesn't get the kind of improvements they thought they were going to get.
And we've actually got a couple of kind of questions on that, Tom. So I know somebody's asked in the chat here on Zoom if a person got misdiagnosed as having lipedema, and I guess that might also relate to perhaps people who've diagnosed through photos or whatever. If they have liposuction, it's a difficult question. If a person's been misdiagnosed with lipedema and has liposuction, what can happen? I guess for doctors like yourself, when you saw the patient to consider liposuction, you would probably confirm their diagnosis or not. So do you want to just kind of perhaps explain a little bit about that?
Well, right. So, I mean, for most people, liposuction is not. I mean, it is a relatively. It's not a surgery associated with a lot of complications. So, but if you're having pain and swelling from your symptoms are pain and swelling, and your goal of the surgery is to relieve those pain and swelling, and that is commonly patients commonly have an improvement in their pain and swelling with the liposuction if they have lipedema, but not necessarily with those couple of things I mentioned. Certainly the iliac vein compression and the partial lipodystrophy wouldn't improve anything. I don't know necessarily that they would be it would be rare that anything other than just not the improvements that were hoped for would occur. But I mean, obviously there is some risk with liposuction or lipedema reduction, and so
yeah, and that's why we always say it's still a form of lipedema reduction surgery. It's an S for surgery, isn't it? So a question that's been asked is, what criteria do you use, Tom, to diagnose lipedema? So would you mind maybe recapping and adding a little bit about what is it this patient has lipedema, definitively?
Yeah, I really follow the whole history, our standard of care guidelines for the diagnosis, but the international criteria for the diagnosis, so symmetrical, disproportionate accumulation of a painful swollen tissue with nodularity that is and with the distribution. Now, it doesn't have to have cuffs. It doesn't have to have lobules, but it can. And but those are, I mean, and then the history, the onset, and the pain and tenderness. Those are really the characteristics we go by. Now, I also do confirmatory testing. So I look at bioimpedance, and I always do a ultrasound, and that is going to be ultrasound will often shows the swelling in the tissues, and it is the subcutaneous tissue does look different. Now those are sort of not as they're used in research, but they are also but they are becoming more validated. We also see higher extracellular water on our bioimpedance, and so those I mean, to be fair, I have tip-offs. I have those extra tests that will confirm and help guide my diagnosis, and they've helped me become better at diagnosing it, and being able to pick up the ones I'm sure that are going to really benefit from the lipedema reduction surgery, and those who are maybe not, and some may still want to proceed, but I really caution them about that. Is that answer?
Yeah, that's good. Thank you, Tom. Can I maybe build on that with someone else's question, where another person has asked what you would say about pain management and about pain in lipedema. So I know sometimes people take different views of whether it's necessary to have pain to have lipedema,
Right.
which is why I think it wasn't diagnosis. So could you maybe just start with, do you think a patient needs to have painful fat to have lipedema? And then what your advice is for patients around managing pain in lipedema?
Well, yeah, that's very controversial. Obviously, I think it's possible to have lipedema, or at least the lipedema prototype, without pain. It's certainly, what do you call it if they eventually if they have all the presentation and they don't have pain? But but if you really are careful and they have at least the tenderness and they don't really report pain. So, Dr. Herbst did recently reported that, most women with lipedema don't have pain all over. The most common area is actually in their calves. And there are some women she has diagnosed who don't have pain. And so that answers that. What was the next part of the question?
So do you have any other advice that you give patients on managing pain in lipedema, Tom? Because people tend to report very disproportionate experiences where some maybe have a lot of pain, some have less. So we've got some people saying things like one person finds the sort of yoga pose, legs up the wall, that inversion to be quite helpful. So just wondered if you'd talk a little bit about advice you have for patients on reducing pain or living better with pain and lipedema. I
great question. So I love to talk about this because there's a significant proportion of ladies with lipedema have something that's triggering their pain. It could be inflammation from their as a result of intolerance in their diet, or even just simply almost all will tell you if they're when they restrict refined carbohydrates that their legs feel better. And then, but some also have actual like gluten sensitivities and dairy sensitivities that when they eliminate that, it also unlocks that they can lose weight in their lipedema areas once they unlock that inflammation. If you're like rashy or you get like your legs are a little redder, that's something that is a tip off that there's more than there's more inflammation. It's more inflamed tissue, and that's going to be more painful tissue. So if you can get to work on the inflammation. Now, compression and elevation and yoga and those things can really improve the inflammation. All those are very anti-inflammatory. We've had everything, and then supplements can help with the management of pain. And we have very, very good data and success with diosmin herpsedin and guafenicin. But other things also are used.
Yeah, no, that's perfect, Tom. And it's interesting for us here because in the UK, I think diosmin is available probably in something like health food stores because that's the horse chestnut one, I think, for people who are wondering. But guafenicin is only available in cold medicine because it's a decongestant. So it's only sold as a decongestant here in the UK. So it's more restricted to obtain it without a prescription.
Oh,
well, so one generally can't in the UK go out and purchase it. So it's an interesting thing for people about the availability of different treatment options.
Yeah. So actually though, horse chestnut's different than diosmin. Diosmin is an extract of citrus peel, orange citrus peel, and herpsedin is just is a mixture of diosmin like compounds. But yeah, I thought in Europe it's a prescription that they do for veins. It's a prescription medication or a prescription supplement for veins. I know in Germany.
Yeah, there are some vein. Yeah, there are some vein supplements, and Germany's a little different to the UK on it. We have a couple of other questions. One person's asking, you talked quite a bit, Tom, when you were talking about lipedema, going back a bit to sort of diagnosis and so on. You talked about lipedema in the legs, and this person's saying they have got painful arms, they get kind of cramp in their arms, and they've been told they have lipedema and lymphedema. Do you have any differences in your view about diagnosing lipedema in the arms, or whether you manage arm and leg lymphedema differently? Sorry, lipedema. Would you just basically talk about your views on arm lipedema for a few moments?
Yeah, so no, for sure it occurs in the like 80% of women with lipedema have it in the arms, and some, I mean, there is this type that maybe more is just in the arm, more in the arms. It's the type 4, I guess, could potentially even occur without in the legs, but that's not how it was originally described. So it does occur. Again, all the same things, the compression, the diet, and surgery, all are used for in the arms.
Perfect. That's great. Do you have thoughts on the fact that increasingly now people are being prescribed GLP-1 receptor agonists, so drugs like Ozempic, Wegovy? Is it something that you have patients who use those and also get lipedema reduction surgery? Is it something you recommend to patients? What's your take on them?
I do. Yeah, I do. We've had a lot of success with GLP-1 agonists. I will, it depends on where they are in their journey. If they are significantly overweight, I will recommend starting them before surgery. Some are some are using it after surgery, and it's not everybody isn't benefiting, but there's a really good percentage that are finding significant improvement from that.
Perfect. I'm going to try and quick fire a couple. If people have, if a parent's got Madelung's disease, can a child have lipedema?
Yeah, I guess,
maybe?
yeah, for sure. Yeah, they're not, and the question is, are they, yeah, for sure.
Yeah,
Well,
yeah. This person's interested, I think, in the relationships. Like, if they have lipedema, could they still develop Dercums at menopause? Basically, do these different fat disorders rule out each other, relate to each other in any way?
I don't think they're mutually exclusive. I mean, I will often diagnose women with Dercums and lipedema. So.
Okay. And do you, as lipomas are often mentioned in articles, is there any connection with angiolipomas and angiomyolipomas and lipedema, Tom?
Okay, so lipomas are more common in lipedema, and then they're the classic definition for Dercum. So there's an overlap there. Now, Dercums are classically associated with more angiolipomas, is more seen, but you can get an angiolipoma in lipedema. I think it's like 5 to 10% of lipomas are angiolipomas. So so that.
I think so. They'll soon tell us if they didn't, if they had any follow-up. Do you think lipedema could be linked with intravenous lipoomyomatosis? I might have got some extra M's in there, I think. Lipoleomyomatosis, I think, Tom.
Oh.
Apologies.
Myomatosis. No, I don't. I'm not familiar with that. I'm not familiar with that connection.
Okay. Perfect. So are there any other, I think we've covered most people's questions. Are there any other kind of real tips that you would leave people with around, in particular, diagnosis and differential diagnosis, and what if they think either that they perhaps have something else as well as lipedema, or kind of really narrowing that in? Because I think a lot of what you're talking to us about tonight is recognizing what lipedema is and what it isn't.
Right.
So what would you want to say to people?
Well, I mean, if they're atypical, if they don't fit the pattern of the disproportionate smaller waist, larger legs, larger arms, if they don't fit that pattern, and then these other things really need to, other possible conditions need to be strongly considered.
Yeah, can I just interrupt here? Thank you, Tom. I'm learning so much. It's just wonderful to have this range of information on different conditions. We've had one question, which is obviously associated with your skills as a surgeon, and how do people find a trusted surgeon? So, if people usually look geographically to somebody they can get to and, and trust. But obviously, if the diagnosis is done remotely and there's a sort of doubt, do you really recommend that people should meet? I suppose leading on from that, you could say, do you recommend people try to meet their surgeon prior to surgery? Or
very, very much so. That really, I mean, that's really the best way, and the way it should be done.
And so the surgeon should really be able to assess the person and, you know, a good surgeon would know about all these other conditions and be able to make an appropriate diagnosis whether surgery was right or wrong. It sounds very logical, but obviously when people have to travel a long way to find what this person has said is a trusted surgeon, it does become more complicated and expensive and emotionally draining for a person who's often making this journey on their own.
Yeah. Yes.
Yeah, there's no easy solution, is there? Yeah. I have one personal question as well, if I can just slip it in before I'm sure you have to go back to your surgery, because I know it's the middle of your day here, for you in the States. One of the things you didn't mention was temperature of the skin. Do you think there is a difference in the temperature of skin in areas affected by lipedema that you can pick up by touch and expertise? That is that the same with some, is temperature of the skin an indicator or not for lipedema, and does it apply in some of these other conditions that the skin can be cooler?
Yeah. No, I do think it is cooler in areas affected by lipedema. And I don't see it. I don't see it in certainly some of those. I do not have the cooler skin, so that might be another way to differentiate them.
Which again is something a patient can almost check for themselves, because in my opinion and experience, cooler skin is very much an indication of where lipedema affects the body or doesn't, because you can literally put your hand over a leg or a thigh or something and you get hot cold, or you know, or normal temperature cold, and maybe that is something that could help patients and surgeons in their process.
Yeah, I mean, mind you, I'm not only a cold-hearted member of Lipoedema UK, but a cold skin one. So as a person with Raynaud's, I'll always say, well, we're like ice cubes. I've had a couple of questions, Tom, if you wouldn't mind just saying, the other conditions you showed us, are they all broadly treatable? I think a couple of people are kind of curious whether people have Dercums, Madelungs, you know, are there options for everybody, even if it's not necessarily lipedema reduction surgery?
Yeah, for sure.
So people should feel confident that if they think they've sat here tonight and thought maybe that's me or maybe that's a friend or something, it's always worth seeking that diagnosis, because there are some options for people.
Yeah, and I think it's just more information. It could have both, you know, but if you have the unusual presentations, you need to understand what that means. And that means, you know, you may you know, you may really have to focus on weight loss, certainly if you have Dercums, and managing that is much more, and Madelungs and Dercums, you know, you're going to get much better results if that's a big part of the treatment. Whereas, you know, where lipedema, pure lipedema, is easier to treat with just liposuction or lipedema reduction surgery.
Perfect. And were those other diseases classed as endocrine diseases, Tom? In the UK, generally, lipedema isn't treated as an endocrine condition. So I think people just are wondering where that boundary is on endocrine conditions with these things.
Iliac vein compressions of venous vascular, the lymphedema is, you know, I don't know. I mean, that's a dermatologic versus, I mean, it's, or vascular, or I mean, it's hard to say. It really does vary by country. Madelung's is more commonly thought of in endocrine. You know, Dercum's is sort of all in somewhere in the middle. I don't know.
Had a really great range of questions, and I think that's captured most people.
Thank you, Kate, for organising the questions. Thank you, everybody who's attended. I think this has been such a fascinating and essential topic. A huge thank you to devoting some of your busy day to sharing this webinar with us, and we hope to see you back in September.